Good morning. I'd like to thank the conference organizers for this opportunity to present on behalf of the PrEP Demo Project team. These are my disclosures. So while several clinical trials have demonstrated the effectiveness of daily oral PrEP for HIV infection, we have heard of several concerns raised, including poor adherence, risk compensation, drug resistance, and safety when PrEP is implemented outside of clinical trials. And several demonstration projects have been recommended to address these issues and determine how best we can scale up PrEP. And public health clinics and community-based clinics that serve large populations of individuals at risk are promising sites for PrEP delivery in the US. The demo project was an open-label study enrolling MSM and trans women in STD clinics in a community health center in the US. Our key objectives included looking at PrEP uptake, adherence, sexual behaviors, STI and HIV incidence, and resistance and safety. And Dr. Stephanie Cohen previously presented and published our baseline data showing high levels of interest and uptake in our cohort. And so I will focus on our longitudinal data today. Here are 3 clinics. Our 2 STI clinics were in San Francisco and Miami, and our community health clinic was in DC. All of these clinics serve large populations of MSM with high annual HIV seroconversion rates of greater than 2%. And participants could either be referred from the clinic and to enter the study, meaning that they were seeking services at the clinic and then were referred to the project, or they could be self-referred to the project after hearing about it in the community. And given that our project was looking to evaluate uptake and interest in these particular clinic settings, we didn't do a lot of substantial other outreach or recruitment for the study. We enrolled HIV negative participants between October 2012 and January 2014. This was shortly after the FDA approved PrEP in the US. These were our behavioral criteria shown here, and this was in based on data in the last 12 months. In terms of medical eligibility, we required a creatinine clearance of 60 or greater, being hepatitis B surface antigen negative, and participants were offered up to 48 weeks of Truvada. Follow-up occurred at 1 month and then quarterly thereafter for HIV and STI testing, client-centered counseling, clinical monitoring, and PrEP dispensation. Now, while our behavioral eligibility reflected the last 12 months, our behavioral assessments were done quarterly and reflected the last 3 months. In terms of adherence, we used several different measures, including self-reported adherence using a rating scale, medication possession ratio based on pill dispensation, and dried blood spots measuring tenofovir diphosphate levels. This was performed in a random sample of approximately 100 participants per site, and we defined protective tenofovir diphosphate levels as having a level of 700 or greater, which in the IPREC study was associated with very high levels of protection and corresponds with roughly 4 or more doses per week. Now, given that we know that retention can also impact adherence, we also wanted to look at what we're calling PrEP engagement, which was defined using a 5-level ordinal variable. And this was defined as for people with the highest level of engagement having DBS levels consistent with taking 4 or more doses per week, followed by slightly lower levels consistent with 2 to 3 doses per week, less than 2 doses per week, having undetectable levels suggesting no recent dosing, and finally completely missing the visit. And adherence and sexual behavior measures were evaluated using GEE and Poisson models. So these were our baseline characteristics of enrolled participants. Our median age was 35. About 20% were under the age of 25. Less than half were white and about a third were Latino, and almost all were male identified. The majority had some college education or higher, and about 3/4 reported any recreational drug use. The mean number of anal sex partners was 11, which is comparable to what was seen in the PROUD UK study. 2/3 reported condomless receptive anal sex at baseline, and about 1/4 had a baseline STI. Our total amount of follow-up was 481 person-years of follow-up, and this is our retention here. Retention at 12 months was 78%. Retention was higher with those with prior PrEP knowledge, as well as those reporting condomless receptive anal sex at baseline, and was lower at the Miami site. So these are our adherence results, and what we're looking at here are the proportion who were able to achieve protective tenofovir diphosphate levels in DBS, and we tested this in about 294 participants. And you can see that across visits, 80 to 86% were able to achieve protective levels. And this was consistent with our other measures of adherence, which also showed high adherence using the adherence rating scale as well as the medication possession ratio. Now you might see that there might be a slight drop-off at week 48. This might reflect people coming in later for their last visit, possibly because they knew that they weren't receiving drug at that visit. We also wanted to look at patterns of adherence over time, and we saw that 63% had protective DBS levels at all visits, whereas only 3% had DBS levels less than 2 doses per week at all their visits. 15% of participants had an interruption in PrEP dispensation, and this was most commonly due to side effects as well as low perceived risk. So in multivariate analyses, we saw that participants from Miami, as well as African American participants, were less likely to have protective DBS levels, whereas those who had stable housing and 2 or more condomless anal sex partners in the last 3 months were more likely to achieve protective DBS levels. And importantly, the odds of achieving protective levels did not differ by age, education, alcohol, or drug use. So this bar graph is now looking at PrEP engagement, and remember this is a 5-level variable, which is color-coded here, with no visit shown in the dark blue, which also appears at the bottom of this bar graph. And this goes up to 4 to 7 doses per week, which we defined as protective levels, which is shown in the lighter bluish gray color at the top of the bar. And what you can see is over time that the proportion with missed visits does increase through week 48. However, the majority of our cohort was able to achieve protective levels even through week 48. And in looking at suboptimal dosing, which is shown here in these colored bars in the middle, we can see a small proportion had suboptimal dosing throughout the follow-up. We did see lower engagement at the Miami site as well as within African American participants, and this may reflect both lower retention and adherence in these groups. In terms of sexual behaviors, the mean number of anal sex partners declined during follow-up from about 11 to 9. And this is looking at the proportion who reported condomless receptive anal sex, and we see that that remains stable at about 2/3 during follow-up. Now, we also wanted to look at the total number of episodes of receptive anal sex that people reported, and we saw that overall that declined, which was largely driven by a decrease in mean RAI episodes with a condom, which is shown here in the green. However, mean RAI episodes without a condom remained stable, which is shown in the red. STI positivity rates were high in our cohort at various sites, including rectal, urethral, and pharyngeal sites where we did testing. We did see some declines from baseline to 24 weeks, with subsequent increases, but not above baseline at week 48. And overall, our STI incidence was high in our cohort at 90 per 100 person years, but this remained stable across quarterly intervals. In terms of HIV infections, we had 3 acute infections that were identified at enrollment. All of them had negative rapid and 4th generation testing at both screening and enrollment, but had a positive HIV RNA at the enrollment visit. One participant did develop FTC resistance with M184V, 1 week after enrollment, this participant was immediately switched to combination ART and has remained virally suppressed. We saw only 2 incident HIV infections during follow-up, and this occurred in the setting of either low or undetectable drug levels around the time of seroconversion, and we did not see evidence of HIV resistance in either of these cases, suggesting that there was low or no exposure to drug around the time of infection. And our HIV incidence in the cohort was extremely low at 0.43 per 100 person years. In terms of our safety outcomes, we saw 23 creatinine elevations in about 2% of participants. All of these were grade 1 elevations except for 1, and only 3 of them were confirmed on repeat testing, of which all resolved without stopping PrEP. There were 12 bone fractures occurred. Most of them were trauma-related, and none of them were assessed as related to Truvada. Our study did have several limitations. African Americans and transgender persons were underrepresented in our cohort, and this likely represents or reflects underrepresentation of these groups in our clinics, as well as possibly lower knowledge and awareness of PrEP in these communities. And it really highlights the need for increased outreach and engagement in these communities around PrEP. Our results may also not generalize to MSM that are being seen in other settings, particularly internationally. And finally, the demo project provided PrEP free of charge, along with monitoring, and therefore the cost and lack of insurance coverage may reduce PrEP access and adherence outside of a study setting, and this needs further evaluation. So in conclusion, PrEP adherence was relatively high among MSM in our demo project, and we saw higher adherence among those at higher risk, which is expected to increase the impact and cost effectiveness of PrEP. Despite high incidence of STIs, we saw very low HIV incidence, and this provides strong support for the scale-up of PrEP in these clinical settings. We do recommend quarterly STI testing, including testing at extragenital sites for MSM that are taking PrEP in these settings. And finally, interventions to address racial and geographic disparities and housing instability may increase the impact of PrEP. I'd like to end by acknowledging our amazing study participants, my co-investigators at the 3 sites, as well as Gilead for donating study drug, as well as NIAID for funding this study. Thank you.